Transfusion therapy. Transfusion therapy is primarily used to treat two conditions. First, inadequate oxygen carrying capacity due to anemia or blood loss. Second, it's insufficient coagulation proteins or platelets to provide adequate hemostasis. Patients require individual plans to meet their unique requirements. Specific blood components are required for specific needs. Whole blood is used to replace the loss of both red blood cells and plasma volume. Rapidly bleeding patients can receive whole blood from type-specific donors. More commonly, the patient receives type-compatible red blood cells and plasma, which are equally effective clinically. Contraindications for whole blood include chronic anemia, where the person has a low red cell volume but has a normal blood volume. If a patient is normovolemic and receives whole blood, they can have volume overload, which can strain the heart. If a person receives a unit of whole blood, their hemoglobin should increase 1 gram per deciliter, or their hematocrit should increase 3%. Red cells are transfused when a patient requires an increase in red cell mass to improve oxygen carrying capacity. If a patient has a high heart rate, has increased respirations, and is experiencing dizziness, weakness, chest pain, and difficulty thinking, these are symptoms that indicate they may need a red cell transfusion. There used to be a 10 gram per deciliter hemoglobin trigger for transfusion, but some people are not symptomatic at this level. If a patient is at 6 grams per deciliter or less, this is a critical level. If a person has a well-compensated anemia, then they don't need to be transfused. Each unit of packed red blood cells should increase the hemoglobin 1 gram per deciliter, or the hematocrit 3%. Additive solutions are preservative solutions added to donor units to increase the out date to 42 days. These additives mean the units have less plasma but more volume. They have a lower hematocrit and flow more easily. The leukocyte reduced red blood cells have white blood cells removed prior to storage. This was not common many years ago, and the white cells would only be removed when the units were transfused. It was noted that there are significant benefits to performing universal leukoreduction prior to storage. The indications for transfusion of leukocyte-reduced red blood cells and platelets are prevention of cytomegalovirus, febrile non-hemolytic transfusion reactions, and transfusion-associated graft versus host disease. Febrile non-hemolytic transfusion reactions means you give them blood and they get a fever, which is caused by the white blood cells or their cytokines, which are in the product. Transfusion-associated graft versus host disease is when the white blood cells in the donor unit attack the patient, which is more common among related donors and patients. The leukocytes must be reduced to less than 5 to 10 times 10 to the 6th white blood cells per unit. Washed or frozen deglycerized red blood cells may be indicated for people who have anaphylactic reactions to ordinary units due to residual plasma. The washing removes plasma proteins that cause these allergic reactions. Freezing red blood cells allows us to store them for 10 years. When we thaw and deglycerize them, it also removes the plasma proteins. Bombay and other rare types may be stored this way. The military stores type O blood units this way to allow for a stockpile of blood. A military hospital in Alaska routinely uses this blood for transfusion, as this allows rotation of the stock. People who have IgA deficiency cannot receive products that contain any plasma from the donors, who are also not IgA deficient. They will have an anaphylactic reaction to the IgA in the donor blood. They must be given washed or deglycerized red blood cells. Platelet transfusions are indicated for patients with thrombocytopenia or abnormally functioning platelets. Platelets are stored at 21 to 24 degrees Celsius or room temperature, so they must be tested for bacterial contamination prior to transfusion. Platelet pheresis components are prepared from one donor and must contain a minimum of 3 times 10 to the 11th platelets. An apheresis platelet should increase the platelet count 5,000 to 10,000 per microliter. If a patient has a platelet count that drops below 50,000 per microliter, they are usually transfused. If it drops below 10,000 per microliter, spontaneous bleeding can occur in the brain. Refractory is a term that means that giving them platelets won't increase their count. To determine if they are refractive, a corrected count increment for platelets is performed. A platelet cross-match is not a routine procedure, but if the cross-match is positive or the patient has HLA antibodies, they are considered alloimmunized. Um, you can go to this link where it says click here, and it will give you a corrected count increment calculator that you can plug in the information to and get the result. A platelet refractoriness is defined as a corrected count increment less than 1700 for at least 2 sequential platelet transfusions, and you would want to try to match the platelets as best as possible to the patient so that they wouldn't destroy them. Granulocytes apheresis is not a product that is commonly used in most blood banks. The criteria for transfusion of granulocytes would be fever, neutrophil counts less than 500 per microliter, septicemia or bacterial infection unresponsive to antibiotics, reversible bone marrow hypoplasia, and a reasonable chance for survival. This product requires a cross-match. The patient must be monitored for resolution of symptoms and clinical evidence of efficacy. Plasma can come in several different forms that are differentiated by the time they are prepared or where they are stored. Fresh frozen plasma, commonly known as FFP, must be frozen within 8 hours of collection. Plasma 24 is frozen within 24 hours of collection. Once FFP or frozen plasma is thawed, it is converted to thawed plasma and the label is adjusted. Both the product name and the expiration dates are changed on the label. Plasma is used in the treatment of single or multiple coagulation deficiencies. If a person has a vitamin K deficiency or warfarin overdose or poisoning, they can benefit from plasma infusion. People with liver disease, such as hepatitis, will also need plasma infusion to replace the clotting factors that the liver cannot produce due to disease. Plasma can be given for the treatment of disseminated intravascular coagulation, but DIC is usually fatal. Plasma and plasma 24 contain all the coagulation factors. Congenital coagulation factor deficiency are rarely treated with plasma. The dose requirements for surgical procedures and serious bleeding can cause pulmonary edema as a result of volume overload. These people will require factor concentrates, which have a higher concentration per volume. There are factor VIII concentrates for hemophilia A and factor IX concentrates for hemophilia B. These can now be treated using recombinant DNA technology, which means that it's not human source. Human source factor VIII concentrates transmitted HIV to many men with hemophilia before we were able to test the blood donations for HIV in the 1980s. Plasma can be used for exchange transfusions. Plasma must be ABO compatible with the recipient's red blood cells. This means that the plasma should not have antibodies to the patient's red blood cells. Type O plasma has anti-A and anti-B and can only be given to type O patients. Type A plasma has anti-B and therefore can be given to type A and type O patients. Type B plasma has anti-A and can be given to type B or type O. Type AB plasma does not have antibodies and is the universal donor for plasma. This looks backwards from the red blood cells, and people tend to get this confused. So think, what antibodies are in the unit of plasma and will it react with the patient's cells? Why don't we care about the Rh type? This is not important for plasma because anti-D is not made unless the person has been exposed to the D antigen, and the donor centers will not label plasma for transfusion that has a positive antibody screen. Take a minute to think about what type plasma these patients can take. Type O is a universal recipient for plasma. Type A can take type A or AB. Type B can take B or AB. And type AB must have type AB plasma. Cryoprecipitate is primarily used for fibrinogen replacement. The AABB requirement for fibrinogen content is 150 milligrams of fibrinogen and 80 units of factor VIII per unit of cryo. Cryo is normally thawed and pooled into a pool of 5 units with 750 to 1250 milligrams of fibrinogen. This is an example of how we determine the amount of cryoprecipitate that a patient needs. In this example, the patient has 30 milligrams per deciliter, and we want to increase it to 100 milligrams per deciliter. The required increase is 70 milligrams per deciliter. So first we convert milligrams to milligrams per milliliter by dividing by 100. So 70 milligrams per deciliter divided by 100 milliliters per deciliter equals 0.7 milligrams per milliliter. Now we multiply by the plasma volume. So 0.7 milligrams per milliliter times 3,000 milliliters equals 2,100 milligrams. Let's continue to the next slide. If we need 2,100 milligrams and there's 750 milligrams per pool, we will divide 2,100 milligrams by 750 milligrams per pool, and this equals 2.8 pools. Then we round up to 3 pools since we can't really give part of a pool. Mild to moderate factor VIII deficiency can be treated with desmopressin acetate or factor VIII. Desmopressin acetate works by causing the release of von Willebrand's factor. Severe factor VIII deficiency is treated with factor VIII only. A virus-safe factor VIII with assayed amounts of factor VIII and von Willebrand's factor is available to treat patients with von Willebrand's disease. This is made through recombinant DNA technology. Factor VIII is used to treat people with hemophilia A, which is factor VIII deficiency. Factor VIII can be produced from pooled plasma or by recombinant DNA technology. The risk of pooled product is the presence of unsuspected viruses that we may not test donors for. This happened with HIV, and many people with hemophilia contracted HIV and AIDS during the 1980s when we did not have a test for HIV since we had not discovered the virus. People who have von Willebrand's disorder will need von Willebrand's factor in their factor VIII. Factor IX, or prothrombin complex, is prepared from pooled plasma. It is recommended for factor-deficient patients who have hemophilia B. Patients with factor VII or deficiency are rare, and selected patients with factor VIII inhibitors or reversal of warfarin overdose may be given factor IX. Albumin is prepared by chemical and physical fractionation of pooled plasma and is available in different concentrations. This may be used as a volume replacement in plasma apheresis or to treat burn patients. Immune globulin can be used for patients with congenital hypogammaglobulinemia and for patients exposed to hepatitis A or measles. Immune globulin is prepared from pooled plasma and is primarily IgG. A leukocyte reduced filter is designed to remove more than 99.9% of leukocytes from red blood cells and platelet products. The products must have fewer than 5 times 10 to the 6 leukocytes remaining in the red blood cells when quality controlled. These are used to prevent febrile non-hemolytic transfusion reactions, to prevent or delay the development of HLA antibodies, and to reduce the risk of transmission of CMV. Blood donors are tested for CMV. Those CMV positive and CMV negative products are produced. Products that are CMV negative are labeled as such. These products may be ordered for people who are CMV negative and at high risk for severe complications if they become infected. These patients include CMV negative pregnant women, allogeneic CMV negative bone marrow and hematopoietic progenitor cell transplant patients, and premature infants weighing less than 1,200 grams or 2 pounds 9 ounces. Irradiated cellular blood components are utilized to prevent graft versus host disease when transfusing or transplantation of immunocompetent T lymphocytes. When there is an HLA incompatibility or the patient is immunocompromised. This is also important when a patient is receiving products from a close relative, as this is more likely to cause graft versus host disease. People who have had an allogeneic bone marrow or hematopoietic progenitor cell transplantation can result in graft versus host disease, which is a syndrome that can affect skin, liver, and gut and can be fatal. These patients who are at risk for graft versus host disease should be given irradiated cellular blood components. A surgical blood order schedule is established by the hospital. It is a list of the types of surgeries that may be performed and if there should be a type and screen or a type and cross-match done for the type of surgery. There are disadvantages of cross-matching for a procedure that has low likelihood of requiring transfusion. You don't want to cross-match and reserve your short-dated units for a procedure not likely to need blood. This can cause an increase in outdate rate and cross-match to transfusion ratio. Cross-match to transfusion ratio that is too high indicates that you are wasting technician time and decreasing available inventory of blood. If someone has a type and screen done with a negative screen, the cross-match can be done rapidly enough if units are required. If an antibody screen is positive, then the antibody should be identified and compatible units cross-matched at AHG. Autologous transfusion is when you donate blood for yourself prior to a procedure. This reduces the possibility of transfusion reaction or transmission of infectious disease. It is a pre-deposit of blood. Another form of autologous transfusion is called intraoperative hemodilution. Blood is drawn prior to surgery, which dilutes the blood so that the blood lost during surgery contains fewer cells than the blood is given back after surgery. There is also intraoperative blood salvage, which collects and cleans the blood that is lost during surgery and returns it to the patient. A patient who is rapidly or uncontrollably bleeding, losing more than 20% of their blood volume, will require an emergency transfusion. These patients may receive group O negative if there is sufficient supply, or O positive if there is not enough O negative available. An antibody screen and cross-match must be performed after an emergency release when time allows. Blood banks are normally able to perform a type and screen and select ABO and RH specific blood for transfusion so that O negative is not wasted on patients who do not require this type. A massive transfusion is considered the replacement of one or more volumes or about 10 units to an adult within 24 hours. This can have a large impact on a patient's clinical status and lab results as stored blood is high in potassium. A patient in critical condition and a limited supply of types specific blood may require a change in ABO or RH types. For instance, in a war zone, you have patients with injuries that may require up to 50 units of blood before the surgery is complete, and there is not usually sufficient O negative in these cases. We want to reserve the RH negative for women of childbearing potential, so this means females of most ages below 60-ish. If a woman has had a hysterectomy or has gone through menopause, they are not included, but a baby girl is definitely uh, uh, included. Premature infants frequently require transfusion of small amounts of red blood cells to replace blood drawn for testing and treat anemia of prematurity. A single unit can be set aside, and a sterile docking device can allow us to take small volumes from the units so that the infant has fewer exposures to foreign blood. All aliquots must be clearly labeled for the patient. The blood that is used for neonatal transfusion requires the same testing as for adults. A unit should be less than 7 days old to reduce the risk of hyperkalemia and maximize the 2,3-DPG levels. The unit should be CMV negative or leukocyte reduced to prevent CMV infection. The blood may be irradiated. The units are usually tested for hemoglobin S and should be negative. Cancer patients may have bone marrow suppression and require transfusion. If the marrow is infiltrated with malignant cells, the patient's marrow is irradiated and replaced with a transplantation. These patients will not be able to make their own cells for a while and will need HLA matched blood components and irradiated products to prevent graft versus host disease. Patients with coagulation factor deficiency will require treatment to replace deficient factors. Blood administration requires positive identification during lab testing as well as before and during administration. There must be procedures and training in place designed to reduce clerical errors. A filter is required in a blood transfusion set to prevent microclots from getting into the patient. The rate of transfusion may be fast if there is a major catastrophic event such as a car crash but if a patient has normal volume, the rate must be slower to prevent fluid overload and cardiac injury. Blood warmers can be used so that the cold does not shock the patient's system. After completion of the transfusion, the patient should be monitored for complications, and there should be a method to let the blood bank know that the transfusion has been completed. Vital signs are done before, during, and after transfusion. Each hospital must have a hospital transfusion committee that monitors the transfusion patterns in the hospital. There must be appropriate criteria for blood transfusion that are used when auditing. The committee should review transfusion practices, transfusion reactions, and ensure that appropriate procedures are in place and are followed by hospital personnel.